We are delighted that the wrap-up speaker, who will also, in the next few minutes, give us his version and his view and his reflections, is also an instructor at AUC, but he's also an entrepreneur. He's the founder of MENA Gurus, and he's also the executive instructor at AUC. Ladies and gentlemen, please welcome Dr. Hesham Abdelghaffar to come and give us his final reflections. As he does that, please keep your questions ready. The microphone is right in the middle. We will use 30 minutes quickly to engage with you. Over to you, Dr. Hesham.
You have eaten 3 minutes from my presentation. And this is my city. You cannot do that in my city. Okay? وبعدين أنا هتكلم بالعربي هو هتكلم بالفرنسية أنا هتكلم أنا كمان بالعربي يعني. I can also speak in Arabic, okay. Which you can do. Huh? All right. Okay. Thank you very much for having me in this great event. Thank you, Dr. Ahmed, and thanks the AUC. I am an instructor of health informatics and information-driven healthcare at the AUC. So I am half an engineer and half a physician. Mm-hmm. Okay, my left brain is an engineer and my right brain is a physician. Okay. Beside that, I'm also an investor in the health technology. I have an investment firm called MENA Gurus, which invests in startups. So I'm mainly going to walk you up through the startup arena in Egypt and speaking about the laws and how to set up your telemedicine practice if you are thinking about setting up your telemedicine practice in Egypt, what to do. Let us first start. This way. Okay. Fast. Okay. So let me first start by giving you a historical preview. What is telemedicine? Actually, telemedicine is a 120 years old term. It started in Australia back in to the 1900s when the first doctor have given medical advertisement over a two-way radio. So this is not something new. This is 120 years old. Wow. Okay. Now move to the definition of telemedicine have evolved into what we call e-health and digital health, and this is according to the WHO. And the main difference between e-health and digital health is what we call the digitally enabled patient. We are now in the era of what we call health retail. What is health retail? The patient is enabled. The patient has the gizmos, have the equipments, the IoTs, the Fitbit, the Apple Watch that can help him monitor his health and give you, the physician, very pretty important information that you can use. So now we are in the era of the digitally enabled patient. And this is a very interesting study that was done by the American Medical Association in 2012. And it was a study for more than 2,000 US doctors. And as you see, 85% of them had given some kind of health consultation over the technology, or what we call a telehealth consultation. And out of the 15% that said no, half of them have given the same during COVID. So that shows you how this is important. This is also a very interesting study done by McKinsey, and it is also very done in 2022. And as you see, there is an estimation that there are as big as 180 million to 265 trillion, 180 billion to 265 billion US dollar are moving from our clinics and our hospitals into the home. So this is happening, gentlemen. This is really happening. Telehealth is coming, and patients are moving from our clinics and our hospitals into home care. Okay? This is also a study done by the American Medical Association, and as you see, the patient that invests 121 minutes of his time to see you, he only stay with you a maximum of 20 minutes, and he lose 37 minutes in a commute and 64 minutes waiting in your waiting room or filling some kind of analog form that he can easily fill online. So out of investing 121 minutes, this patient can save 100 minutes by taking the consultation from home. Come on. Okay. So if you want to set up any telemedicine consultation, I'm going to mainly speak about Egypt because the gentlemen have speaking about other countries. So let me concentrate on Egypt. If you want to set up a telemedicine practice, you have to look at four main pillars: the legal, the clinical, the financial, and the technical. The legal aspect is a big issue in Egypt because unfortunately we don't have a telemedicine law till now. Also, the first real, true startup that have started giving a kind of telemedicine services in Egypt was back to 2012. It was Visita. Of course, before Visita, 2012 was the establishment of Visita, which is our booking.com for doctors. And but before that, there were many trials, I know, but the serious one was 2012. So we have been practicing telemedicine in Egypt for 10 years, yet we don't have a law. Okay, but right now I'm happy to tell you that we are currently in the process of making a law, and there is Gahar is leading, which is our accreditation body. Gahar is the Egyptian accreditation body for the gentlemen that are not from Egypt, and they are leading a great exercise to try to come up with a community service to know all stakeholders, and I'm actually participating in this workshop myself, and it's great. And we are taking experiences from other countries, like from France and from the NHS and from also Saudi Arabia. They have a great telemedicine law in Saudi Arabia. They also have a great telemedicine law in the UAE. So you have to first check the legal framework, and the legal framework till today is not there. We have more than 20-25 telemedicine and telehealth companies actively doing great business in Egypt, yet we are still outside of the boundaries of the law. And this is, by the way, is very typical with technology. If you remember Uber, the regulator had to chase Uber for maybe 2 or 3 years to catch up. And so hopefully this is going to happen for us. So the legal framework, you have also to look at the clinical framework. And the clinical framework is what kind of services are you going to give? Are you going to give physician to physician, physician to patient, physician to other healthcare professional? And there are totally different approaches in this. And what kind of services are you giving? Emergency, allowed, not allowed, specialty, dermatology is okay, maybe teleradiology is acceptable. All these are issues that you have to consider very carefully. This is one of the workshops that I attended is by Gahar, and as you see, the physician to physician was welcomed by 100% of the participants, physician to patient by 76%, physician to other healthcare professional by 71%. This is, by the way, was done last month. So this is very recent study, a workshop that was led by Gahar, and I participated in it. Okay? Now go to the financial part, which is of course a very important part. Maybe it is not that important in Egypt now because 60% of our patients pay from their own pocket, but with the new healthcare law coming in, we are going to see a lot more reliance on the payers or on the insurance. So is the insurance going to pay for this or not? What kind of payment are they going to pay for the teleconsultation, for example? The same they pay for the face-to-face. This is not the case in every country, by the way. Some countries they pay less for the teleconsultation over the internet than for the face-to-face. Others they don't. So you have to, as a practitioner, consider that and agree with your insurer or your payer on that if he's going to pay you the same. It's a big, important issue that we are also trying to find a solution for. If you look at this review also done in Gahar, by the way, I welcome Dr. Ahmed Safwat, who has invited me to this great workshop, and this is one of your slides, sir. With your permission, I'm sharing it. You asked us to share it everywhere, so I am taking your advice to share it. Please, we are going to, Dr. Safwat and the Gahar people are going to put all the funding from this beautiful workshop online, so for us, the community of physicians, to give our feedback and try to help those that are shaping the law to shape it according to our need. So as you see, teleconsultation they should be paid by 95% of the attendees say the teleconsultation should be paid, telediagnosis 89, and telemonitoring less and less. Okay, finally the technical aspect. As we said, this is teleconsultation or you are giving a telehealth over the technology. So how technologically ready you are. You as a doctor, are you able to use technology? And unfortunately, we see one of the main problems I personally see with Egyptian doctors is the reluctance to use technology, especially in booking. I don't know, this is a tricky issue since all of you are doctors, but I am also a doctor like you, so I can really say that this is something we have to work on it. We have to be maybe more courageous to adopt the technology. But I think with younger generation, this is not an issue. My generation and the older generation of our professors, of course, we have to work more on that. But the technological issue also has another problems and limitations when it comes to delivering services to rural areas where you have a concern over the quality of the internet. If you are doing teleconsultation and you are a dermatologist, for example, and you are relying on the quality of the image to diagnose, that's a big issue if this is transmitted over poor internet. I know the country is doing a great job now improving the bandwidth, but I think this is an issue which we have to be very careful about. No. Okay, come on. Well, I want to finish my presentation by showing you this beautiful picture, which is a picture of Dr. René Laennec. Dr. René Laennec is the one that invented the stethoscope that we are all very proudly use in our practice, and this was back in 1816. So what exactly Dr. Laennec have done? Dr. Laennec have just stepped away a bit from the patient. And by stepping a bit away from the patient, he was more able to diagnose it. And this is, if you think of it, exactly is the concept of the telemedicine. Let us step away from the patient through a virtual screen and try through this virtual screen to communicate with the patient. Thank you very much for listening. I appreciate your time.
Thank you, Dr. Hesham. Let us all step away from our seats and go to this microphone. And if you can just, as you raise up, just go and stand behind this microphone. And as you can, I'll start with you, of course, and then you can stand there and take the next question. And we will take questions and have, before we do that, wasn't that an interesting panel? Wonderful. Did you all enjoy? Did you all learn?
Wonderful panel.
They deserve a great round of applause. Please introduce yourself and go ahead with the question.
Good morning. My name is Shuhaib, Dr. Mustafa Shuhaib. I headed the medical governance for the South German Health Group. My question is about economics. Now, the impact of telehealth with all its branches, as our colleagues in the panel have clearly explained, do we have a clear or an example where, like Shiran just mentioned, this is a wide spread access but cheaper option.
Right.
So it's going to be cheaper. What would you say to the private sector who is used to seeing a certain number of outpatients every month? Now this is going to go down because some of these are going to be, and so on. So do we have a clear example of these economics and the impact on a private sector in the experience of those who started it?
Thank you, Dr. Hesham. We'll take you on mass and we will answer that. Please note it down. Can we have the second question? And Gada, you can go third after this.
Okay. Good morning.
Good morning.
Thank you for the panel. My question goes for Ian.
Introduce yourself as well.
I'm Dr. Islam Atay, I'm a physician. I'm asking about the impact of your study or your project for using telemedical devices on quality of life of your patients. I think it has been 18 months from now and you have the data. If you can share it with us. Thank you.
Okay. Thank you. Ian, you've got that quality question. I'll take Dr. Gada first and Dr. Wanga after that. Gada.
Good morning. My name is Dr. Gada Ganzouri. I'm presenting Ganzouri Hospital and also the deputy for the private healthcare providers chamber. Thank you. My question is to any of the colleagues or the eminent speakers. How did you face the challenges of the reimbursement of this service? How did you lobby to get the insurance to pay? And also the legality and validity for the malpractice, because many patients who does not see the doctor, they might claim, well, I think you made a mistake, and they can sue the patient or the organization as malpractice for the misinformation or mismanagement of information. Thank you.
So Tony, I will take that one, if you can note that one down, reimbursement and malpractice. Wanga?
Oh, thank you. They were wonderful presentations against which I want to take a stand. So please bear with me.
And do introduce yourself so the people know.
I'm Dr. Henry Wanga from Kenya and the incoming president of Africa Society of Radiologists. I'm an intervention radiologist and I'm glad that you cannot transfer my catheter through my dawa. Now, how many physicians have said these questions, of which survey the American University in Cairo professor said? The response was very good, physician to physician. But how many physicians said the questions? The next one is, you've shown us the stethoscope, Planek. I agree, I used it. When did you move away from Hutchinson's clinical methods? Because you first take the history, bond with the patient, examine the patient and investigate. I agree, medicine can be prescribed, but how do you bond with the patient on the phone?
Yes. I'm going to ask Robin, how do you bond? You've done a lot. You take that question, number 4.
Thank you very much.
I'll take the last 2 questions and I'll go for the answers.
Yeah, my name is Muhammad Ali. I'm from IQV operations in Middle East, but based in Cairo. I have 2 comments. We discussed before the session with Dr. Ahmed about we have a platform called Shamil connecting all the ecosystem piloting in Egypt. We have 2 observations we noticed. Adoption for doctors are very, very, very low. When we do webinar, for example, and we invited some doctors even in the region, we found only attending 170, 200, 300 max to attend a webinar. When we see any song, in any non-even familiar song, you find 1 million, 2 million views. So we need to increase and see how doctor can adapt more to webinar, if even it's useful or not useful, but to try to link. Other comments for Mr. Robin for Kenya application. We have here in Egypt some legal issue with pharmacists. They believe teleconsultation or teledispensing will affect their economies, and they lobbied on syndicate of pharmacists, and they stopped some applications to dispense medication out of pharmacies. So how we can overcome those points?
Thank you
very much.
So Tony, you noted that, and Dr. Hesham, adoption by doctors, I'll ask you to answer that question. Last question and we answer. Go ahead, Professor.
Hello, I'm Dr. Mohammed Twali, Vice Dean of College of Pharmacy, Arab Academy, and also I'm healthcare analytics consultant. I'm asking about, are there any studies conducting concerning cost utility or cost effectiveness as a comparative study between the new era or the new trend of healthcare versus the as usual or routine care. Are there any bulk of evidence regarding this point? Thanks a lot.
Thank you so much. Okay, let me begin by Ian, if you can talk about quality, and then I will go to Tony after that. So Ian, over to you on the quality aspect.
Thanks, Amit. We've got a whole raft of data that's available now, certainly in relation to how we've targeted on the COVID virtual ward and the benefit that we've seen and the reduction in aspects of length of stay, but also associated to the quality piece and the patient experience perspective of it. The ability to share data, the ability to have collected some of that key data from those patients that resided within the COVID virtual ward and then also within the wider remote monitoring perspective, being able to share that across multidisciplinary teams, wider and broader care pathways that that patient may already be on, has been really beneficial and really supported from that perspective. We have got data that's available nationally, so the NHS, from an NHS perspective, we do publish an awful lot of data, which is accessible through the website.
Thanks. Let me move to the questions on reimbursement. Tony, reimbursement of services, and then the legality and validity of malpractice that Gada asked. What do you, how did you get the insurances to pay for the service?
It's a struggle. I mean, one of the main things is probably still in Kenya, at least 80% of the services that we provide are paid for by the patient out of pocket. So the out-of-pocket expenses is one that's easy. We've got a number of payment methods to do that. Insurance companies is much harder. Now, we're a completely digital business. So we've actually...
Is the phone? Okay, click the phone.
They're on the floor.
Okay.
As a completely digital business, we're able to provide the insurance companies everything digitally. So we can provide the prescription, the claim form, the invoices. We can provide the date and time that it was uploaded, who the doctor was, etc., everything. But insurance companies want me to print that out at the end of every month, send them a ream full of paper so that they can process those manually and then give them to an outsourced provider to digitize for long-term storage. So it's a nightmare in how to do that. And it's just a constant fight to ensure that we're able to get that payment.
Okay. Thanks, Tony. And maybe, Robin, you want to add to that what we were discussing? And also, can you talk a little bit about the question of bonding that Dr. Wanga asked? Will you be able to still bond with the patient remotely? What's your experience?
Yes, for the insurance, I'll speak on the public side because that's what happened in France. In terms of experience, there was two sides, but the lobbying started first with the medical professionals and mostly the professors, which were pioneers in telemedicine, created a union of professors wanting to push for telemedicine, and that's how the topic started, and that's how the law was created back in 2009. And then when the companies came and the startups, the lobbying went to Parliament as well, because in France we have each year a healthcare financing law which defines what will be the budget for the next year, and everything is published and debated and so on. So the companies took strong lobbying to all the Parliament members and politicians to do so. It even went up to the minister himself, the president, and there was also strong lobbying to the presidential team in 2017 when he came, and that's how in 2018 we got the reimbursement from the health insurance, 1 year after President Macron came. Okay. For the bonding, actually what we see now with large scale is that it doesn't really create any additional issues, and in fact, it's the opposite side, and it's actually more bonding. Why? Because the patient controls the environment. He's in his home, in his room. It doesn't have to be in a frightening office, massive office with the doctor speaking and you're like that as a patient. You're in control, and actually patients are much more confident. They speak more, they're more open, they're more relaxed. And that creates a bond which is different than the physical bond, but it's a different bond. It's a digital bond, the same way that we may have a bond by chatting with colleagues that we see less. And that's how it is. Even for remote patient monitoring, without seeing the patient, even audio or video, but there's a trust that is established by saying, okay, we work together to do this.
Right.
Yes.
Let's just say we agree to disagree with some of the doctors here will be saying the bonding will be improving less, but we can talk about it after the session. Thank you, Robin. Dr. Hesham, now coming to you, you know, Professor Mohammed Metwali and I think Dr. Mustafa asked a similar question. Mustafa was asking about the economics and Dr. Metwali was asking about the cost effectiveness. So talk to us about the numbers. Are the numbers adding up in telemedicine, and do we have something that you can share with us?
Well,
and the impact on the private sector. Before I
well,
come
let's speak
Sharon.
about, if we would like to speak more about the Egyptian case. We definitely have no way to scale healthcare to the population without telemedicine, because the current situation in Egypt with the percentage of doctors to patient, one of the lowest in many countries, is our only way to scale up universal health care is through telemedicine. We have no other option. Is that going to affect the economy on the private sector? And it should not, because most of the countries are treating telemedicine consultation and give them the same fees as the face-to-face consultation. And let me put it this way. You are not changing your practice of medicine when you use telemedicine. You are just changing the tool. You are using a different tool, but you are still the same doctor and you are still giving the same service, even if you are giving it from behind the virtual screen. The effect is going to happen on the change on the business model. And this is what the McKinsey study have showed. Because the McKinsey study have showed that business will going to move from our clinics and our hospitals to the home. So it's up to you, the physician, to go to the home to chase this business that is moving away to the patient home. That's why we say that telemedicine is now the new house call. Let us go back to the roots. The roots, when we started this profession 7,000 years ago, the physician used to go to the doctor. Okay, it was not the other way around. We used to go, when the pharaohs were practicing medicine, they used to go to the patient. So the physician go to the patient. Now you have a tool to go to the patient house without leaving your office. You can go through the virtual screen. But if you think that this is going to be different after the pandemic, let me tell you, no, this is only going to get worse and worse if you don't chase it. If you chase it and you change your practice and you set up your business in a way that you can take advantage of this, you can scale up and you can see more patients. Actually, you can see more patients using technology.
So Dr. Hesham, you think that this telemedicine is going to be the growth factor for private sector?
Definitely.
So that's your answer.
If we do it this way, if we are smart enough to think of it as another addition to what we can do.
Right.
Okay?
Right.